Now, I would invite our next speaker. She's Dr. Sommayya Aftab, Associate Professor, Pediatric Endocrinology, Department of Pediatric Endocrinology and Diabetes at the University of Child Health Sciences, Lahore. She has played a pioneering role in advancing the care of the diabetes and education regarding diabetes in the country. And she would speak on congenital adrenal hyperplasia, dilemmas in diagnosis and management.
Well, thank you so much, sir, for this kind introduction. And first of all, I would really like to thank New Colloquium for inviting me on this prestigious platform. And I'm a bit nervous today because I'm presenting in front of my teachers, Professor Taid Ahmed Bhatt, Professor Tahir Masood, Madam Jayada. So that is a great privilege for me to present in front of all of you. Can you share my slides? Okay, so I'm given a task to talk about congenital adrenal hyperplasia, diagnostic dilemma and management. I have nothing to disclose, but I just want to make a request that I'm sharing some sensitive images on this presentation. So please avoid taking pictures for these images. Even I have taken a consent from the family while I share these images. I really want to start my presentation by certain thought-provoking scenarios. So this was a boy who presented in our clinic at the age of 2 months with a concern of bilateral undescended testes. The parents were consanguineous, and apparently they had family history of 3 sibling deaths with the same complaint. Honestly, the family was just concerned about there were undescended testes, and when we did a lot of the workup, this boy was actually 46XXCAH, 21 hydroxylase deficiency. We realized to an extent that the genitalia look like a male. So just imagine that this family has lost 3 kids for a preventable and manageable condition, and they presented in emergencies and in neonatal emergencies with a concern of undescended testes. Another scenario, we received a call from A&E. A 10-year-old boy presented with concern of hypertensive heart failure. And somehow, when they try to catheterize that boy, they find out there's some ambiguity on genitalia. When we did a workup, this boy was again 46XXCAH, 11 beta hydroxylase deficiency, and hypertension is actually a part of that type of CH. Again, just imagine the agony that this boy has lived 10 years as a boy, and actually she is a female, a normal female, reproductive and fertile, but because of misdiagnosis in newborn age, they have to go through all this pain. So I really wish after 20 to 25 minutes, we all will be able to understand what are the different types of CAH and what are the different clinical presentation in neonatal life, how to confirm the diagnosis and manage them. I'm sure you all know about the definition of CAH. It is a group of autosomal recessive disorder where you have impaired cortisol synthesis due to several enzymatic defects in steroidogenic pathway within adrenal gland. And overall, worldwide, the incidence is reported 1 to 10 to 14,000 to 18,000. If we really want to understand about a CH, it is very important to know how the different type of CH they actually present. Congenital adrenal hyperplasia pathology lies in adrenal cortex, which has 3 zones. And it is not just simple 3 zones, it's a complex cascade of a lot of enzymatic reactions ongoing, producing a lot of hormones. And we need to understand that all these different type of hormones, they are linked to each other. If you look at that, this zone is zona glomerulosa, this is fascicle theta, and this is reticularis. It produces aldosterone, this is producing cortisol, and this is producing sex hormone. So let's start how different type of CH can present. So if we have a blockage at this point, 21 hydroxylase deficiency, which is actually the most common type of CAH, what's gonna happen? You can clearly see from the picture, there is no aldosterone, so definitely these babies will be salt loser. And there's no cortisol, they have increased ACTH and pigmented. and all the byproduct is start diverting towards sex hormones. So female will be having an atypical genitalia and the male will have a normal genitalia. Why the male have a normal genitalia? If a male fetus gonna get a lot of androgens, it's not going to have an atypical genitalia, because for a female fetus to get an atypical genitalia, they need to have under-virilization, not over-virilization. So that is why the most common type of a CH in boys present with a normal male genitalia. The second type is 11-beta hydroxylase. We do see a lot of 11-beta in Pakistan because of a risk of consanguineous marriages. And again, interestingly, they do have low cortisol, so they have raised ACTH. Again, the male are having normal genitalia, the female are having atypical genitalia. But if you look at the pathway, they don't produce aldosterone, but somehow they are hypertensive. Why? Because the precursor deoxycorticosterone has more mineralocorticoid activity as compared to the aldosterone. So when it start accumulating in the body of the baby, they start getting hypertensive. And that was the second case I presented in the first slide. There's another type, 3-beta HSD. You can see the pathway is basically producing no aldosterone, no cortisol, no sex steroids. So again, they will be having very bad salt losing, hyperkalemia, hyponatremia, hypoglycemia. And because there are no sex steroid production in this type, so the male will be having under-virilization, atypical genitalia, and the female will present with a normal genitalia. So the female will have a female-like. But if you look at that in 3-beta, we observed a lot of kids born with a virilization. What is the reason behind it? This DHA sulfate is actually a potent androgen for a female. So that is why they start getting a virilization. Then you have some rare types, 17-alpha hydroxylase. I'm not going into detail of it. Just to let you know that these children also present with hypertension and they are under-virilized male, and the female are also having a normal female genitalia. Star mutation, we do have star cases. Again, if you look, this is the first step in steroidogenetic pathway. So there's no aldosterone, no cortisol, and no sex hormones. So male will born with female-like genitalia, the female will born with a normal female genitalia, and definitely they are very bad salt loser. I really want to spend some time on this rare type, which is actually not rare in Pakistan, aromatase deficiency. This is the only type of CH in which the baby, when came, there's a history of maternal virilization. So during pregnancy, the mother start getting history of acne, hair growth, because the aromatase enzyme actually located within the placenta, and that is why this high androgen, they start getting virilization of the mother. So whenever you have a history of maternal virilization, think about aromatase deficiency. So we learned so far a female 46XXCH at the time of birth, it can present with atypical genitalia, means varying degree of virilization. And again, it could be a simple clitoromegaly, atypical genitalia, and a Prader scoring 4, which means a genitalia is absolutely look like a male genitalia, but definitely she's a female, so it's not going to have any gonads in it. And rare type of CAH can present in a female with absolutely normal female-like genitalia. It's, again, for 46XY-CAH, the most common type of 46XY-CAH, they used to present with a normal male-like genitalia, but again, rare type of XY-CAH, they do present with varying degree of under-virilization, starting from microphilus to hypospadiasis, and in rare star mutation, a male can born like a female genital appearance. So I think there's a very strong message here. Please do not assume gender of a patient by just looking at genitalia. And even if you are having a baby with absolutely female-like genitalia, please do palpate inguinal area, because sometimes the gonads are present in inguinal area. So we need to palpate that. So if you want to just sum up, 46XX-CAH, baby with normal female genitalia, think about star mutation. But 46XX-CAH with atypical genitalia and salt loser, the most common is 21-hydroxylase and 3-beta. And if it's not salt loser, interestingly, 21-hydroxylase also have a salt, a simple virilizing type, and 11-beta steroid is also a non-salt loser, actually hypertensive form. 46XY-CAH, normally they are born with normal male genitalia, And if they are salt loser, always think of 21 hydroxylase deficiency. But if they are non-salt loser, think of simple virilizing type of 21 hydroxylase or 11 beta hydroxylase, which later present with hypertension. But if 46XY born with ambiguity, if it's a salt loser, 3 beta and star is the most common mutation. And if it's a non-salt loser, think of 17 alpha hydroxylase, which is actually a very rare type. From now onward, I'm mostly going to talk about 21 hydroxylase deficiency because more than 90% cases of CH are 21 hydroxylase deficiency. It is caused by CYP21A2 gene, and more than 300 mutation has been reported so far. And we have already discussed they are salt loser, female are ambiguous, and male are having a normal genitals. The important thing is that this salt losing episode never present within first week of the life. So if you do a sodium and potassium within the first week, it turns out to be normal. Do not assume that this baby is not a salt loser, because apparently these babies start losing sodium and retaining potassium after second week of life. So this is a very important message. And that is why most of the male, they passed away because they were not picked up early in the neonatal care. The female, they got attention because of ambiguous genitalia. So it is very important that if you have any concern, any male with a concern of loose motion, vomiting, dehydration, please think of CH. I'm just skipping it because 21 hydroxylase has 3 different types. In neonatal life, we always came across a salt wasting type. Simple virilizing and non-classic do not present during newborn age. Let's talk about the newborn screening program for CH. I really wish that it is available in Pakistan, but how internationally and all over the world we do it, it is performed only for 21 hydroxylase deficiency because it is the most common type of CH, and conducted after 48 hours of birth, measure 17 hydroxyprogesterone level by radioimmunoassay. Why this matters? Because it enables early diagnosis of life-threatening salt wasting, prevent mortality, it allows timely initiation of glucocorticoid and mineralocorticoid, it reduces the risk of incorrect sex assignment in virilized females, and definitely improves a lot long-term growth and developmental outcomes, and reduces the stress of the parents too. What is the limitation for this screening program? You know that 17 OHP levels are greatly affected by the time when the sample has been taken, gestational age, birth weight, birth stress. There's a lot of false positive 17 OHP if you took within first 48 hours of life, in premature, low birth weight, stressed baby, ill baby, and there are certain other type of CH which can have mildly raised 17 OHP. And you could have false negative 17 OHP if the mother is taking dexamethasone as an antenatal therapy, or she's taking any other steroids which is very potent and cross the placenta. Whatever the screening is, you need to confirm it by the serum testing of 17 OHP. There is a 2 type of screening programs that is running all across the world. One is the first try screening and second try screening. The second try screening, after the first screening by 17 OHP, if the levels turns out to be positive and borderline, they do tandem mass spectrometry for 17 OHP, endocynidione, cortisol, 11-deoxycortisols, and this second try screening is basically done after 1 week or 2 weeks, and it is more specific and has more diagnostic accuracy. If you follow the NBS programs, different centers have different cutoff levels, but most centers in states, they take 25 to 75 nanogram per ml for a normal birth weight baby. But the problem arises when the baby is preterm and if the baby is having a low birth weight. A lot of work has been ongoing to find out what are the cutoff for the preterms and what are the cutoff for the low birth weight baby for the newborn screening for CAH. There was a very interesting study published in 2005 by Vanderkamp in which he gives a cutoff for 17 OHP as per the birth weight. And in the same article, he also gives the cutoff for the gestational age. But now the question arises, if the baby is having a prematurity and the low birth weight, which table we need to follow? So in 2019, Podesheket did a very extensive work, and they somehow put both of these together, the birth weight along with the gestational age, and then they decided that these are the centiles for their cutoff. So if the level of 17 OHP is more than 99.97 centile, take it as a positive newborn screening for the preterm and low birth weight. I really want to recommend that newborn screening program shall incorporate screening of CAH due to 21-hydroxylase deficiency all over the world, and at least in our part of the world where we don't have newborn screening program, at least suspect CAH in any child born with ambiguous genitalia, unexplained vomiting, dehydration, shock, hyponatremia, hyperkalemia, metabolic acidosis, hypoglycemia, or hyperpigmentation. It's very important that after getting the newborn screening, you need to confirm the CAH by getting these chunk of blood tests, 17 OHP, urinary steroid profile, sodium, potassium, aldosterone, renin, ultrasound pelvis if the baby is having ambiguous genitalia, and karyotyping if the baby is having atypical genitalia. And these are the level that is recommended for serum 17-hydroxyprogesterone. So basal or stimulated 17 OHP, if they are more than 300 nanomole per liter, they are very strongly indicative of classic 21-hydroxylase deficiency. Let's talk about the managing CH. Managing CH is not a simple job. It needs neonatologist, pediatric endocrinologist, pediatrician, geneticist, urologist, and psychologist. Principle of management is counseling of parents, oral glucocorticoid, mineralocorticoid, sodium supplementation, sick day management, monitoring, and genital surgery in case of over-virilized female. Again, I would like to request all the neonatologists, please, whenever you see a baby with 21-hydroxylase deficiency or CH, please spend time with the family to educate them. Your baby is a normal male or a normal female, and it's a medical condition, it is not a stigma, because especially when a female baby is born with atypical genitalia, people took it as a stigma. So you need to counsel them. These are the normal females. They have a medical condition in which they are producing a lot of male hormones, which we can manage by replacing lifelong glucocorticoid, and we can prevent their failure to thrive by giving mineralocorticoids, and you need to give stress dose at the time of sickness. And you also need to educate them about its autosomal recessive nature, because in every pregnancy, there's a 25% risk of getting the same baby. So this counseling part is so important, so that in order to help the family and to release their anxiety. What is the goal of managing CH? Honestly, for me, you need to prevent adrenal crisis, you need to prevent hyperandrogenism, but you need to make it sure the child should be growing normally and achieve the puberty with a normal pattern. If we talk about the glucocorticoids, there are different types of glucocorticoids available: hydrocortisone, prednisolone, dexamethasone. If you look at them, hydrocortisone stays in your body for 6 hours, prednisolone for 8 hours, and dexa 12 hours. This is duration of action for glucocorticoid activity, not anti-inflammatory. But the growth suppressing effect of hydrocortisone is very less. So please, in children, always start hydrocortisone. Prednisolone and dexamethasone is not recommended in pediatric population because of their growth suppressing effect. Another important point, try to give hydrocortisone 3 times a day and 4 times a day. Do not recommend twice daily regimen. The reason is that hydrocortisone just stays in your body for 6 hours. If you want to give half tablet even in the morning, after 6 hours, there will be no cortisol in the body. And what happens in the end, the baby will start getting cushingoid, but he will actually having less cortisol. The disease is not controlled, because if you look at this picture, in which the BD doses of cortisol was advised is, so there's a gap, this gap and this gap. So for 12 hours of a day, there is no cortisol in the body, ACTHs rise, androgens are rise, it will never end up in a good control. So always give hydrocortisone 3 times a day or 4 times a day, total divided doses. Recommended dose is 10 to 15 milligram per meter square per day. I always thought that why the Pakistani babies, they need higher dose of hydrocortisone than across the world. The reason is that most of the consultants, they used to give twice daily dose, and that is why they keep on increasing dose. I was like, no, don't increase the dose. Please split it up. And when you split up the same dose, after a month, you feel like, oh, actually, this baby needs less dose. Mineralocorticoid, infant kidneys are very immature and less responsive to mineralocorticoids, so they need high dosing. Interestingly, hydrocortisone itself has a mineralocorticoid activity. So when the baby grows, their hydrocortisone dose start increasing. gradually their mineralocorticoid dose start going down. Please, those of you who tried to prescribe prednisolone and dexamethasone, Dexa and Pred has no mineralocorticoid activity. So if your CH patient came to you with pyomeningitis and you want to advise dexamethasone to cover a brain, start mineralocorticoid because dexamethasone has no mineralocorticoid activity. Normally we start fluorocortisone with a dose of 0.05 to 0.2 milligram per day in a 1 to 2 divided dose. We always recommend the salt supplementation 1 to 2 gram per day, and as we have discussed, as the child grows, the requirement of fluorocort gradually decreases. Sick day management is very important because this is one of the most common reasons they used to come to our hospitals. So if the baby is having a fever, gastroenteritis, major surgery, please ask the family to double the dose of glucocorticoid, and I strongly recommend to give additional dose at 4 a.m. if you are giving 3 doses. And no need to increase the fluorocort dose, and the family should have hydrocortisone at home and train the family how they can give hydrocortisone in the case of dying emergency when they're rushing to the hospital. And for the newborn, the dose is 25 milligram, just start intramuscular and then rush to the hospital. Crisis, always suspect a crisis. If a CH baby came with nausea, vomiting, diarrhea, pain, and always give hydrocortisone. If you don't know the dose, just give 25 milligram if the child is less than 1 year, 50 milligram if it's more than 1 year, and 100 milligram if it's more than 5 years. And after that, start calculating 100 milligram per meter square per day. And even if you don't have the time to calculate the surface area, just give 1 to 2 milligram per kg per dose every 6 hourly, depending upon the need of the baby. And if you feel your baby is in a shock-like state, hydrocortisone infusion is recommended. For the newborns, just 25 milligram hydrocortisone per day is more than enough. But if you give as a continuous infusion, and if you give as a continuous infusion, you check cortisol level, you aim for a cortisol level of 800 to 1000 nanomole. And then you feel, oh, from hydrocortisone point of view, my baby is safe. And when you're managing crisis, do manage the dehydration and do manage hyperkalemia and do manage hypoglycemia. Assessment, that is another aspect. When you refer a baby for a CH after discharging from nursery, please do tell them that this baby is gonna need 1 monthly assessment for next 3 months, followed by every 3 monthly till the age of 18 months, and after 18 months, every 4 monthly. On an every visit, we need to check length, weight, BMI, height, velocity, blood pressures, and when they grow up, pubertal progression and cushingoid features. For hydrocortisone dosing, we always follow 17 OHP ACTH cortisol. We always aim to keep 17 OHP slightly on the upper range. Do not suppress this too much. In Great Ormond Street Hospital in a very developing country, they do the 24-hour cortisol profile, which I personally feel is too much, but they normally do that to make it sure which dose they need to increase, morning, evening, and night. But at least in our setup, at least do ACTH 17 OHP. For mineralocorticoid dosing, you need to have a sodium, potassium, and plasma renin activity. Plasma renin activity is very important. Many times I saw the patient is having a normal sodium and potassium, and plasma renin is more than 500. The baby is trying to compensate, and he has a lot of chance to go to dehydration on slight illness. You really want to keep a plasma renin within a normal range, so please make it sure that at least 6 monthly do plasma renin activity. We recommend bone age after the age of 2 years annually. And that is from pediatric endocrinologist, that if the babies we are suspecting having advanced bone age and entering into puberty, you start doing some chunk of gonadotropin levels. Surgical treatment, if the baby is over-virilized, we need to plan clitoreduction and vaginoplasty. If under-virilized, urethroplasty, scrotoplasty, or orchidopexy. This is again an important aspect. Prenatal treatment of CAH. We all know that prenatal dexamethasone given to the mother prevent the virilization of affected female baby. But prenatal treatment with dexamethasone shall be considered experimental after taking IRB approval and parental consent. And these are the recent guidelines for last 10 years. So honestly, I don't give prenatal DEXA because there are concerns of maternal safety and fetal safety. And you can see it can produce cleft palate, IUGR, behavioral issue, and long-term insulin resistance is one of the complication, and somehow you are making other babies who are actually not CH exposed to all these risk factors, because we do not have CVS here, we do not have advanced genetic testing so that we can confirm that we are giving this steroid just to the affected female. Psychosocial support is again very important. I really feel that we need a proper psychologist who know the basic understanding of CAH, and there's a strong need of CH peer support group. Unfortunately, our department had just started working on it. I'm just going to share you, this is the burden of our hospital in CAH. Every year, we are receiving almost 100 cases of congenital adrenal hyperplasia of different types, and these numbers keep on increasing. And in last 3 years, 16 cases of 46XX CAH. They presented very late, and they were reared up as a male. Even they were a female. And their mean age of presentation was around 10 to 11 years. The problem was that their genitalia looked like a male. Their Prada scoring was 4 and 5. This was a very difficult decision because they have lived as a male for last 10 to 15 years. So we normally used to do a gender rear a proper clinic in our hospital to assign a gender in such situation. This is my last slide about the take-home message. We all know that CH is a life-threatening but treatable neonatal emergency. Suspect CH in any newborn with ambiguous genitalia, unexplained shock, vomiting, or electrolyte imbalance. 21-hydroxylase is the most common cause. Female may be virilized. Male infant may look normal and present later with the crisis. Elevated 17-OHP is a key diagnostic marker. Please do not delay treatment. If you think of CH, let's say you don't have lab, start the treatment because you can lose a baby. Early diagnosis and lifelong hormone replacement ensure excellent outcome. These are my references. I really want to thank my department who are actually working day and night, my nurses, my paramedics to manage these kids. And this is our beautiful city, Lahore. I think most of you are from Lahore, but those who are not, I really find this slide very appealing for me. And thank you so much. And I think we take question at the end. Thank you.
Okay. Thank you very much, Dr. Sommayya. Now, we have got 15 to 20 minutes for questions. So the first two presentations are now open for questions and comments. So any questions from the first presentation on Professor Haq, and then any questions on Dr. Sommayya's presentation. So Professor Haq's presentation is open for questions and comments, please. Yes, Dr. Junaid, yeah.
Sir, I have very simple question. Maybe it is like a stupid question. So we all agree, and I discussed with you also agree that we don't have the definition and the number of that. Now the problem is, sir, we are doing universal glucose screening in all newborns, and we choose some number. That is the number that we asymptomatic, as you said, we don't treat, but we choose some number, and that number in our unit is 1.4. And if the baby is asymptomatic, we just ask the thing to feed the baby and then repeat the glucose. And if the glucose is increasing, and fine, otherwise we have to treat. So I need your comment on that. Is anything what you said about the universal screening to do in all the babies?
First question, answer to you. Please sit down. The first answer is there is never a stupid question. Questions are always welcome, and questions should be asked. And in fact, everyone should asking questions. Now the question is one number. You have chosen 1.4. That's fine. I cannot advise you on any particular number. I gave you what number we use, 2. That's up to you. 1.4 is fine. Now, if the baby is well, feeding well, and asymptomatic, just continue feeding. Don't do anything else. The glucose will come up gradually. It will take time, but it will come up. But make sure you're giving adequate nutrition, adequate feeding. It's not that you just put the baby on the breast and then take it away 5 minutes later. Breast milk, breastfeeding should be minimum of 25 minutes to 30 minutes before the blood sugar rises. So yes, I would agree with you. You should. Now, the next question is whether we should do universal screening. Now, two things about universal screening. One, you will detect asymptomatic hypoglycemia. And what will you do about that? Supposing it is 1.2 and the baby is asymptomatic. Why your cutoff is 1.4? So why are you changing? The point is, you don't know. So if it is your unit is 1.4, stick to that. Don't change. Don't say, well, this is 1.2, but the baby is well, so I will continue. No, you need to do something about that till you get to 1.4. Make it number, whichever number you like. All I've said is there is no number which I can give you for definite, that this is the number you must do.
Sir, sorry.
Oh, Sikandar, please.
Sir, again, a very simple question. Maybe you have actually targeted in your presentation, but as you have mentioned that there are no specific symptoms. Usually there are non-specific. So, and you have mentioned again there is no threshold for numbers. So what should be the threshold for clinical condition at which we have to intervene?
Yeah, I think there is Marvin Kornblatt in 1967 suggested that we should have every neonatal unit. You can read that paper in pediatrics. It's an old paper. That every unit should draw its own threshold when it can do or when it start treatment. So I would advise you, I can't give you a number for your unit. Look at your data, look at your numbers, and decide what threshold you are going to use. My threshold I've given you, 2 to 2.6, but your threshold may be different. The reason why your threshold may be different is because you have a higher incidence of growth-restricted babies as compared to my practice. I don't see that many growth-restricted babies. So I see more extreme prematurity. So I see more hyperglycemia than hypoglycemia. So there is a difference in practice. But the answer to your question is, Sikandar, is you need to decide what your threshold is when you will start treatment. I don't know the answer to that. I can't give you a number.
So again, I'm not talking about number because you have actually not given the weight on numbers. I'm talking about clinical condition, whether it should be the CNS manifestation or the general symptom. What should be the clinical,
Excellent.
threshold?
Excellent. I showed you that our clinical diagnosis is about 30% sensitivity and specificity. So we are not very good at clinically diagnosing hypoglycemia unless it goes down to 1.5, 1.7 when the baby is tickling and having convulsions. So we are not very good at clinical diagnosis of hypoglycemia, just as we are not so good at diagnosing sepsis clinically. So I think it's important to realize that if you cannot diagnose it clinically, then you have to depend on something. Whether you depend on intermittent monitoring or continuous monitoring. But what I would suggest to you, if you are having a difficulty in establishing a guideline, look at the high risks. Those babies who are at high risk, monitor them more carefully. Those babies who do, because about 30% of them have high risk. And so monitor those babies much more carefully. The others, I think clinically, if they are asymptomatic, you don't need to do anything, whatever their number is. So develop a algorithm for your own unit as to when the clinical signs and symptoms in the high-risk babies, you will start doing something. The other reason why you should include high-risk babies is because the long-term outcome in high-risk babies is worse than for the same blood sugar level in babies who do not have risk. Whether it is the sugar which does that or the associated high-risk factor which does that, we don't know.
Thank you.
So, there are 3 questions here.
Thank you. Professor Haq, we have a very explicit and elaborate presentation. You mentioned about physiological hypoglycemia. since the relationship with the symptoms that is poor, and and you said that mostly the newborns are asymptomatic. So what is the harm in treat? You said that there is again a controversy whether a newborn's physiological hypoglycemia should be treated or not. What is the harm in treating that? Because the symptomatology is not that related with the level of glucose.
Quite right, sir. The problem is when you give glucose, you increase the cerebral flux of glucose. And so the cerebral cortex gets a huge rise in cerebral glucose, which is toxic to the neuron. So there is harm of giving an asymptomatic baby glucose, because you may cause neuronal injury. And that's related to the reactive oxidative substances which are released.
Assalamu alaikum. I'm Dr. Rees. In continuity with Sartar's, when we treat a hypoglycemia in our setups, we need a number. Asymptomatic, even if it is asymptomatic, when we treat asymptomatic hypoglycemia with a number, then we monitor. And you said that the harm starts from when the level goes beyond 150. So
that is hyperglycemia you're talking about.
Yes. So the harm starts when it goes beyond 150 milligram per deciliter.
No, I'm sorry if I did not make it clear. I showed you that there is no consensus of when you diagnose hyperglycemia from 125 to 270. And there is no evidence that 125 is better than 270.
Sir, let me phrase this way. If we treat a number and then we have a cut-off upper limit in our mind that it should not rise beyond 120 or 150, what is your comment? Because we don't generally, as you say, clinically, it's very difficult.
The long-term outcome, if you have a cutoff at 125 or you have a cutoff at 270, the long-term outcome in hyperglycemia is no different. No different at all.
Because we have to treat, obviously, with a number.
Beg your pardon, sir. Why do you have to treat? You said you have to treat. Why do you have to treat?
Because clinically, sometimes we feel difficulty in establishing symptomatic hypoglycemia. And when this baby starts flickering, then it's probably...
You've changed to hypoglycemia. I thought we were talking about
hypoglycemia. No, we are talking about hypoglycemia, treating with a number.
Yes, I'm not quite sure that if you're... One thing is very clear, what I hope, I'm sorry that I did not make it clear. If you're asymptomatic, no matter what level, there is no evidence that treating it is good. That's number one. If you're symptomatic, then it is good, advisable to treat. That is, and whatever number you are. Once symptoms occur in hypoglycemia, that's bad. That's the whole reason why we screen. We screen so that we can detect hypoglycemia before symptoms occur. But we don't know when symptoms will occur and whether we should treat, and we decide a number and we take a number to treat. But that is not robustly evidence-based. That's what I'm saying. Sir.
Bismillahirrahmanirrahim. Thank you very much, sir, for nice and always been listening to you almost for 25 years, and we always enjoy. So two things. One question I'm repeating, that is the same of Dr. Junaid and Dr. Sikandar. I think everybody asked about it. On one side, we say that asymptomatic hypoglycemia, it is not causing damage. On the other side, we say symptomatic hypoglycemia is a medical emergency. Now, how to fill up the gap between the two? This is very much. And the second question is about, sir, hyperglycemia, when it stays for a longer duration, then it is causing retinopathies in adult people. It takes how much time for a neonate to cause a retinopathy of maturity for hyperglycemia?
I think if I understand your question correctly, I keep on stressing that we do not have clear diagnostic criteria. We decide a number. I showed you the range.
Yes, of course. Got it, sir.
I cannot give you a definite number when you should treat. You have to decide that yourself. And there is no evidence. If somebody asks you, why did you choose that number? You can say there is no evidence why I should not. If you choose 2.5 versus 2.6, why? I don't know. I have no idea. So that is one thing. Now then you come to treatment in a symptomatic baby. Yes? The symptomatic baby, if you think it is due to hypoglycemia, then you should treat. But the symptoms are non-specific. And therefore, if it's non-specific, how do you know the symptoms are due to hypoglycemia? And the way of diagnosis now is what the neuroradiology will do for you. But other than that, you do not know at what level neuroglycopenia occurs when the brain is lacking energy. So these are difficult questions. My apologies to you, but my purpose of presenting this is to raise your thought process, not to give you all the answers. It is to raise your thought process so that you start thinking about it. And it's not that simple. This level, do this. This level, do this. It would be nice. But if I can upgrade your thought process, I would have done my job.
And about the second question about how much time it takes to hyperglycemia to cause retinopathy of prematurity.
How much time does it take for hypoglycemia to cause neural damage? It depends on various risk factors, and it depends on gestation. The more immature the baby, the earlier the damage. The more mature the baby, the later the damage.
My question is from Ma'am Sommayya Aftab. I'm Dr. Aisha. I'm from PIMS Hospital. I'm fellow pediatric endocrinology. So my question is, ma'am, your presentation is very nice. We have learned a lot. So my question is that we usually receive babies in emergency or in IPD, and the patients already received hydrocortisone or dexamethasone because of any illness. And we received a call to assess the baby because baby has hyponatremia and hyperkalemia. In that scenario, should we send all the panel of CH and start treatment, or should we only send 17-hydroxyprogesterone and start treatment of CH? Because we have to make lifelong diagnosis in that case.
So honestly, that is a very important question and very common scenarios actually. So if you have started a treatment, first of all, you need to manage that life-threatening crisis. To be very honest, if the baby is having hyponatremia and hyperkalemia, maybe if the family is affording, you can send the samples, but otherwise what you can do, first stabilize the patient, because even in developing country, what they do after that, they hold the hydrocortisone within hospital setting for at least 12 hours, and after that, you can send the whole panel. But in our circumstances, the baby normally, they are in severe crisis. They were having severe low sodium and high potassium. As far as my experience is concerned, 17-OHP and ACTH take times to come down, but there's no fun in taking cortisol level when you are already giving hydrocortisone, so do not take cortisol level. And if you're giving dexamethasone, cortisol level will definitely turns out to be low because dexamethasone suppress cortisol production. So if you really want to do, just do ACTH and 17-OHP. If it turns out to be high, then you know that your diagnosis is right actually. But otherwise, if a child came late to you, maybe after 10 months, 11 months, we normally do in children's hospital, we admit the patient. In hospital setting, we stop the hydrocortisone for 12 hours. For dexamethasone, it should be 72 hours actually. You need to hold that, and now we keep on monitoring for the blood glucose, blood pressure, sodium, potassium, ECGs, and then we do that test. The second thing is synactin test. You can do a synactin test. Just hold the hydrocortisone, and after that, do a proper synactin test to make it sure 100% this is a CH or not.
Thank you, ma'am.
Sir, what we normally see in a baby in the first 12 to 24 hours is this baby is probably exclusively breastfed. So small colostrum, volume of colostrum, probably that baby is high reliance on gluconeogenesis and ketone bodies in the first 24 hours. So my question is, sir, should the glucose target differ in an exclusively breastfed infant in the first 12 to 24 hours?
Yeah, I think if you have started breastfeeding early, colostrum is not that rich in glucose. It is rich in fatty acids. It is there to provide energy to the baby in a smaller volume. So, and fatty acids then convert into glucose. So if you are able to breastfeed a baby as early as possible, colostrum or milk feed, you will reduce your incidence of hypoglycemia like that.
That's
think
what
the message is very clear that breastfeeding as early as possible, Colostrum is, if possible, otherwise definitely breastfeeding. But Rehan, as I showed you, that is Harris's study published only last year. He has shown how long does it take for the breastfeeding, for the blood sugar to rise. It takes about 25 to 30 minutes. So,
Yes, my question pertains to the diagnosis of this, especially 21 hydroxylase deficiency. You rightly pointed out that in first 24 to 72 hours, because of immaturity of adrenal enzymes, there is likely to be a surge of rise of 17-hydroxyprogesterone, and so would be true in the preterm babies, and that is the reason you would require a later diagnosis. My concern generally is in the newborns, especially the baby boys, who would have suggestive endocrine electrolyte picture of relatively low sodium and high potassium, even potassium going up to 6.5, and their scrotal sacs scrotum would also be hyperpigmented. And in fact, I remember two of these patients in whom the endocrinologist had advised the enzyme replacement therapy, not enzyme, the hydrocortisone and mineralocorticoid, but later on genetic screening, they turned out to be not suffering from 21-hydroxylase deficiency. So what to do with these, 17-hydroxyprogesterone is always, there are pitfalls in actually the assessment of these patients based on 17-hydroxyprogesterone. So would you recommend that the Senectin test, which you mentioned, that should be done before actually the diagnosis is confirmed?
So thank you so much again for such a practical and a common scenario. So I do believe that Senectin test should be done actually in every case, but because Senectin is not available in Pakistan, that is our limitation. What points are pointed out is that if you have a baby with hyponatremia, hyperkalemia, definitely you are concerned, and you're really concerned about losing a baby, and you started mineralocorticoid. And many times, sometimes, this high potassium could be because of a squeeze sample, and it could be because a sample kept in a lab for hours and hours, and there is factitious hyperkalemia. But I always say, whenever you have a hyponatremia and high potassium and ECG is having a tall T wave, please treat it. Because the reason is that the factitious hyperkalemia never produce the ECG changes. And sir, your second question is that we do have other conditions which mimic like CAH, like hypoaldosteronism, like pseudo-hypoaldosteronism, absolutely normal male genitalia, absolutely normal female genitalia, but they are salt loser. For me, from a CH point of view, potassium is more important than sodium because other causes of failure to thrive, they normally have hypokalemia. If you have renal tuberosidosis, if the patient is having septic and is not taking orally, they normally used to have low potassium. The only problem is the way you took a sample. So I always recommend, okay, please take a free flow potassium. Then I call the lab. I really want a lab within 1 and 2 hours to make sure it's not a factitious rise of potassium. And so thirdly, even I encounter a few cases who were labeled as a CAH because their sibling were CAH and they were just carrier. The carriers sometimes do present in neonatal life with slightly hyperkalemia and hyponatremia. But later when you see the patient, you feel like their hydrocortisone dose is not increasing. And somehow their plasma renin activity start getting suppressed on the treatment. And then you start thinking about, oh, there's something else that I'm thinking about. So you need to follow the patient also. Thank you,
Okay,
sir.
thank you. This will be the last question, please.
I have a query from both the speakers. Sir, you have said there is no universal definition of hypoglycemia, but is there any recommended time for universal screening of hypoglycemia after birth, like let's say soon after birth, 1 hour, 2 hours, or 4 hours? And my second query is from the second speaker, that if we have 46XX CAH and we encounter later in life, for example, if we have encountered 1 to 3 years, and I had a few patients like this, and one of them really, the baby has been reared as a boy, was actually XXCAH. The father was a Maulvi in a masjid at the village, and we really had difficulty in convincing him that this girl. So what should be done in these scenarios? What help can we have?
So honestly, we are facing this very commonly. A 46XXCH presented at the age of 10 years and they want to rear up as a boy. We normally used to do a multidisciplinary team in which we have a urologist, a surgeon, endocrinologist, and psychologist. If you ask me if a baby is having a Prader scoring of 4 and 5, from surgical point of view, it is difficult to rear up as a female. And after the 2 year of an age, if the baby brain start getting a lot of androgen, there is a term called andronization of brain. They start behaving like a male. So mostly for the Prader score 4 and 5, if they presented at the age of 8 years and 10 years, after discussing with a multiple disciplinary team, psychological assessment, revealing the gender identity, we also rear them up as a male, but we need to do for hysterectomy and then oophorectomy, and it's a proper tedious work. They need to go for 3 monthly, every month assessment. The whole team discussed that we are taking this decision in the best of interest for that patient because we cannot force a baby to be a girl who is actually living for 12 years as a boy.
Okay, thank you very much. We close the question answer session for the first 2 lectures now, and we proceed to the next presentation, and that is I'll invite my co-chair, Professor Amin Jan, to invite the next speaker, please.
Thank you, Professor Salman. It's my pleasure to introduce Professor Khalida Hamayu. She's a Professor of Pediatric Endocrinology, Department of Pediatrics and Child Health, Aga Khan Hospital, Karachi. She is the Director of Pediatric Endocrinology Fellowship Program as well. She's going to talk about the transient आप कहना चाहते थे? जी मैडम.
So we'd like to take a few comments from Professor Taid Bhatt before we start with the lecture. Professor Taid Bhatt, sir.
Okay.
Well, thanks for giving me the opportunity to express myself also. I just have to comment something on the antenatal treatment of the mothers. So when we go through the literature, we find that there's a lot of controversy and the effect of the dexamethasone on the neonates' brain development. There's a controversy. But if you look at the literature, even a guy in New York and somebody in France, they just don't agree to that. And they still continue. And in our country, what we have seen is, well, because I've been involved for the last 30 years in the practice of endocrine in babies, what we have seen is that if you treat the mothers, and most of the babies will not be virilized female babies, obviously we managed according to a plan. And if you don't treat them and they are born ambiguously, believe me that some of these babies are abundant and they never get the same sort of parental care which they deserve. So the point is that what should we do in this environment? We are not Americans, or we are not in the Western world where things can be managed in a different way. But here, the social pressures in the families and effects on the baby who's born ambiguous, shouldn't we go ahead and till things really clear up, we go ahead with the treatment of the antenatal CAH babies?
So thank you so much. So honestly, sir, I 100% agree with you because the level of stress, anxiety the family faces when a baby is born with ambiguous genitalia, especially in our circumstances, is too much. So we can do it, but we need to take parents' proper consent and we need a proper approval. For example, I gave few patients the antenatal steroids, but I totally explain each and everything. And the second thing why I feel it's sometimes difficult, because they are not happy for getting the CVS sample, or they were not happy to get the gender identification done, because we need to start dexamethasone within 6 weeks of getting pregnant. So you are exposing all the babies, male and female, the mother is carrying, and the risk is just 25%. And so there's a lot of stuff now that it do cause maternal safety concern.
No, but generally, the males are not exposed for the whole pregnancy, obviously. only the females are actually exposed
Yes, sir,
to it.
exactly.
So the thing is there any study which differentiates between the female babies who've been on dexamethasone throughout 9 months and male babies who were exposed for the first 10 weeks or so? Is there any difference in the
yes, sir. So now,
brain effects and any
yeah.
of those things?
So now what they are doing for in those center where they are giving antenatal dexamethasone, within first 4 week of getting pregnancy, they checks the DNA sample from maternal blood to confirm the gender XY, XX, and even before even confirmation of pregnancy, they give antenatal dexamethasone. So they actually given a very controlled setup. That is my concern, because dexamethasone do cause hypertension in mother, it do cause IUGR baby, it do cause maternal cushingoid features, it do cause a lot of other side effects. So maybe we need to be very cautious while prescribing dexamethasone. The mother should be on a proper follow-up with the gynecologist. She need to take care of herself. And then the baby birth weight, even I have seen IUGR baby because of dexamethasone, because previously we used to prescribe that.
What I mean to say is that our experience has been very different, because the babies we treated with, the mothers treated with dexamethasone, the baby acceptance was high, and the baby's abandoning was not really heard in those babies, though they continued treatment. So should we follow the Western suggestion that don't treat them?
So honestly, I again feel it's a bit debatable, because when you tell the family, because some people feel giving antenatal dexamethasone means it will somehow treat the baby. It's not treating a baby. It's just correcting the genital virilization. And once the baby is born, you need to somehow confirm that the baby is having a CAH. And after that, you need to start patient on a treatment for lifelong. And somehow by giving antenatal dexamethasone, we also lose one of the most important tests, 17-OHP. You can't test 17-OHP if the mother is on antenatal dexamethasone. And we do not have genetic testing available for any patient.
Well, you can't stop the
Yeah,
dexamethasone because the mother-in-law doesn't like it. You have to make a scientific decision.
Thank you very much.